joint replacement after native septic arthritis. This problem is a quite serious problem. We try our best in most patients to try to get rid of that, but despite all our best efforts, many of times the joint can get completely destroyed, and this leads to a very serious problem as to how to get these patients back to some kind of function later on in life. What are the issues with this is, first is, what is the risk of for this joints getting reinfected after you do a joint replacement? Then the question comes as to when do you want to do this surgery? What are the tests you're going to do before you do a joint replacement? And what are the strategies you use? So what we are taught and what makes sense is that the longer the time duration, the safer it is to do a joint replacement. A lot of studies have shown 5 years, even 5, 7, 8, even much more than that out. But recent studies have shown that even done within the first 3 to 6 months, as long as you are certain that you have got rid of all the infection, you do your tests. If the knee or the hip is very quiet, then you can do it even at 3 to 6 months time. It's very important in these patients to be sure that you have got rid of all the infection. What tests would you do pre-op? You can do CBC, ASR, CRP. Now, if these tests are normal, that does not necessarily rule out any infection in the joint. If these tests come raised, then we must be cautious, try to check a serial trend. Joint can be tapped. A tap which does not grow anything does not again prove that the joint is not infected. It does give a low yield, but it's a good test to perform. You can do CT scans and X-rays to plan your surgery. So once you do all these tests, the next thing you need to decide is whether this joint is a quiescent joint or not. If the joint is a quiescent joint, which means you have reasonably ruled out, and you can never be sure, that's why I'm saying reasonably ruled out that this joint is now okay, you can choose whatever surgical strategy that you want to, whether you want to do a 1-stage or a 2-stage. A lot of these patients come with bone loss, bone defects, etc. So it's good to have all your sets on standby. Send deep tissue, send deep fluid. You may want to use a frozen section also. Post-operatively, till you get back the result of the culture, broad spectrum antibiotics. In case it grows something, then obviously you need to change your strategy then. If the joint is not so quiet, which means either you have grown something which was there in the first infection itself, or it's a new organism that's grown, this joint is still infected, so we have to treat it accordingly. The same principles, 1st stage, 2-stage, 1.5 stage is now something which is much more talked about, but most centers would want to do a 2-stage for this. During the 1st stage, you have to completely get rid of all the infection, complete synovectomy, small cysts, etc. are in the bone. You just want to get that all out. Then you use your spacer, and then you come back for a 2nd stage as planned. What are the results of these? Despite all our best efforts, the rates of recurrence of infection in these patients is from 4 to 12%, even more in certain studies. Whether you do a 1-stage or a 2-stage, well, you can do either. There is a lot of literature which has come out in the last few years which says that see, if you have a quiet joint, a 1-stage is a reasonable option. For a joint which seems infected, then it's better to do a 2-stage procedure. So this is just a case which I have done. This patient came during COVID, so 2020, when there was a first wave of COVID. He was there in the hospital for 1 month. He developed a hospital-acquired infection. When he came to us, he came with this picture. You can see that there is the loss of joint space superiorly on both sides. So this patient was then taken up for a 1st stage of a 2-stage procedure. You can see that there is complete loss of cartilage and there is a lot of synovitis all around. So this head was excised. I put in a cemented hip in this patient with Vanco and meropenem. This patient was told that this is a 1st stage of a 2-stage procedure. The growth from the deep tissues was actually different from what they had got from the first joint aspiration. This was the patient at about 10 weeks or so when we stopped the antibiotics, gave him a break for 2 weeks, checked serial CBC, ESR, CRP. When we were certain that it's all good to go in, so at about 3 months, took him up for a 2-stage, which was again done in a staged manner. There was no loss of bone while removing those loosely fixed implants, and hence we could get away with a routine primary hybrid total hip replacement. This patient is now about 3 years out and is infection free. Coming to the last aspect is what about tuberculosis? Now, I think we have very well established guidelines as to what to do with patients whose joints are infected with TB. We all know that even in the presence of TB, we can do a joint replacement. The controversy still exists as to how many days or weeks prior do you want to start the patient on the treatment for the TB. What is said is about 4 weeks at least, but the best is about 2 to 3 months if you have that much time. When you're doing this patient for surgery, you need to get rid of again all the cysts and send all samples off for a test again. Post the surgery, about normally 12 to 15 months or even longer of the TB medication. In the presence of a sinus tract, in the presence of gross soft tissue involvement, or if it's a drug-resistant tuberculosis, then perhaps you want to consider a 2-stage procedure in these patients. Cemented or cementless hips have not been shown to have any issues. Reactivation of TB has been shown. There is one case report which has shown this happen even at 37 years after the primary hip replacement. So it's not an uncommon issue. The host factors, so if the patient is someone who's generally weak or he's not taken his drugs properly, is the one who's more likely to land up with this problem. Most of the times they are just managed with restarting the drug therapy. So the take-home message is that this is a very serious and major issue. If you have a past history of a septic arthritis, 4 to 6 months gap at least should be given. Try to do a 1-stage if all your tests are normal, if your joint is absolutely quiet, or then just shift to a 2-stage procedure. Thank you.